Good afternoon to everyone. Our IC is on comprehensive aspects of strabismus management, and our first talk is by Dr. Namita. She's a consultant in pediatric ophthalmology and strabismus in Giridhar Eye Institute, Kochi. Over to you, Namita.
Good afternoon all. At the outset, I thank KSOS and Dr. Rajni for giving this opportunity. So my topic is on when strabismus doesn't mean surgery. So does all squint require surgery? So the answer is no. There are some which can be managed with non-surgical management also. So who are the candidates? Those with small angle strabismus, those who are young with poor cooperation in whom a consistent angle measurement is not obtained, or those who are waiting for surgery to buy time. So it helps in alleviating the strabismus symptom and improve control of squint and binocularity. So these are the non-surgical management we usually try with optical management, medical management, amblyopia treatment and orthoptic exercises, where prism and botulinum tox will be covered by the other speakers here. Optical correction, in the presence of strabismus, any amount of ametropia is recommended to be corrected, and the gold standard is a cycloplegic refraction. So these are the usual cycloplegic drops and ointment we use to prescribe. And keep in your mind that cyclopentolate has to be avoided in patients with CNS disorder, and in very young who have a stronger accommodating component, it's better to use an atropine refraction, that is atropine 1% ointment in a rice grain size twice daily for 3 days, and always inform the parents about the side effects like facial flushing, fever, dryness of mouth, etc. So coming to the refractory and esotropia, mainly hyperopia. So any amount of uncorrected hypermetropia, which can produce a retinal blur, which in turn can stimulate accommodation and accommodative convergence. And if the fusional divergence is insufficient, the patient can develop a refractory accommodative esotropia. And if it is a sufficient fusional divergence, patient will develop only esophoria. And if the AC by A ratio is flat, the patient might not even develop any squint. This explains why some patients with hypermetropia develop squint and some might not. So the main the esotropia which develop in hypermetropic patients are normal AC by ratio accommodative esotropia, that is refractory accommodative esotropia, where the distance and near angle will be almost similar, and usually it starts in around 2 years of age with moderate angle of squint and moderate hypermetropia, in whom the full cycloplegic refractory correction, if it's given, the patient deviation will reduce to less than 8 prism diopter. As shown the case, the child, after giving the full cycloplegic refraction, she became almost ortho. Other one is high AC by ratio accommodative ET, where the amount of convergence is excessive to the amount of accommodation needed, and the near deviation will be more than distance with high AC by ratio, in whom the treatment choice is bifocal, that is executive bifocal with a flat upper segment which bisect the pupil, and we usually give in the increment of 2.5 to 3 and gradually weaned off 9 to 10 years. As seen in this child, she was doing well with hypermetropic correction for distance, but she has a esotropia persisting for near with the hypermetropic correction alone, but with the bifocal segment she's doing ortho. There is another entity, partially accommodative esotropia, where despite giving the full correction, patient will have an ET persisting for distance and near more than 10 PD. They might require other modalities of management. As shown in this child, despite giving the full cycloplegic hyperopic refractory error, he had a residual ET which was treated later with the surgery. Coming to the refractory error correction intermittent exotropia, the rule is any amount of myopia, there is full correction is needed. Astigmatism, better to correct it fully, and hypermetropia, always the rule is under correction. As shown here, the myopic correction itself helps in controlling the iris in this child. Also, there is over minus lenses, which was introduced by Kaltrader and Jambolski. So here, what they give is -2 to -4 diopter access to the cycloplegic refraction, especially in younger child with deviation around 5 to 15 prism diopter. What this lenses do is it stimulates the accommodative convergence and reduce the angle and frequency of exodeviation. The reported success is around 50%, but if the patient develop any asthenopic symptom, diplopia, esotropia, it warrant discontinuation. And the greatest concern is inducing myopia in a non-myope and progressing myopia in a already myope. So it was extensively studied by the PEDI group, that pediatric eye disease investigative group. They found that the over minus lenses helped in better control of intermittent exotropia for distance. However, that effect did not persist when the treatment was weaned off, but the greatest concern was 15 times there was increase in the risk of myopia in the over minus lens group. Later, it was actually prematurely terminated. Later, the refractive error change was further studied, and they found that though there is a myopic shift that persisted even at the end of 3 years, but it did not exacerbate or neither lessen the myopic shift. Other treatment modalities, amblyopia treatment in the form of occlusion, penalization, or in the form of Bangarter filter by depriving the better eye. And also there are software-based therapy like Revital Vision, which based on the perceptual learning principle, which uses the Gabo patches. And coming to orthotics, when the goal is to increase the range of fusional convergence and divergence, it includes anti-suppression exercises and fusion exercises. In convergence and insufficiency, the patients usually present with asthenopic symptom, and on examination there will be receded NPC, exophoria greater for near than distance. The modalities of treatment can be started with pencil push-up exercises, cat card exercises, or Brock string exercises, or even the software-based exercise like try exercise, that train your eye exercises, which comes in different modules for convergence and even divergence training. Divergence insufficiency, the patients generally comes with difficulty in distant vision or intermittent diplopia for distance and asthenopic symptoms. There will be esophoria greater at distance than near, poor near, negative fusional vergences. And for them, we can give even eccentric circle card and also the software-based programs. In acute acquired comitant esotropia, there are different types, of which the Belchowski type, mainly seen in uncorrected myopes. There, if the angle is small, we can give even the divergence exercises. Even the binocs have a squint ease platform that's mainly to help in controlling intermittent divergence squint. I'll take you through a few other cases also. Not all squint requires surgery. So this boy was brought to us with complaints of squint and was referred for squint surgery. On examination, he had a right exotropia. On further examination, he had a disc pallor in the right eye. We did a detailed evaluation which showed total thinning of RNF in both eye. And field test on the better eye showed there was a temporal hemianopia. So thinking it could be a chiasmal lesion, we ordered a MRI also, which showed there was a craniopharyngioma. Another child who brought by parents with complaints of squint and on slit lamp examination found to have a congenital cataract with posterior capsular dehiscence and was taken up for surgery. And another patient, this was an elderly patient who had a history of status post paracavernous meningioma, radiation done, was referred by the neurologist with diagnosis of sixth nerve palsy. On examination, extraocular movements were full. However, on eccentric gaze test, there was a eye get locked in each position, and the diagnosis was confirmed to an ocular neuromyotonia of third and sixth nerve, and was referred to the neurologist, started on membrane stabilizers, and she's doing good post-treatment. To conclude, all cases of squint doesn't require surgery. We need thorough evaluation. Some cases may require even neuro evaluation. Thank you.
Thank you, Namita. If one question I could ask to the panel, I would ask Nina ma'am, regarding the use of over minus lenses, what is the age group you recommend? Does it recommended in all children? I have seen that in the adolescent group, they generally don't tolerate minus lenses. So what is your recommended age group, and for how much of deviation you recommend giving it?
I don't generally use over minus lenses, but if I have to use, it would be for an intermittent exotropy in a very small child in which I am not sure about the angles. I want to buy some time and I want to wait for some time before surgery, or a child is not cooperative for any other modality of treatment. It would be preschoolers, definitely, not anybody who is going to school, because as you said, they will not tolerate, and there is a risk of myopia progression. Maybe Dr. Sandra can add.
How frequently, ma'am, you have seen myopia progressing with over minus lenses? Does it really progress? And okay, thank you.
By the time she gets ready, when do you advise patching in intermittent XT, madam?
Yeah. So that's very controversial. So if the intermittent XT has very good, excellent control, I don't do anything. I just observe. But if it's got you feel that it's the child, parents are saying child is squinting more than 50% of waking hours, and you are not sure about your angles. You don't want to operate before 4 years of age, or you haven't got any angle to operate on. You just have a Krimsky reading. That's a time I may try alternate eye patching to buy time. Again, it's not based on any evidence-based study that I have done, but parents have said it is helpful in controlling the deviation. What is your experience?
The same, but definitely it improves the angle. Like the control and the angle does improve till you can get good measurements. So the same criteria you can use.
Good afternoon to everyone. So my talk is on prisms in strabismus, a handy tool in ophthalmology armamentarium. So we know that prisms have been used everywhere in ophthalmology, and starting from the basic diagnostic test to all the ophthalmic instruments. So, but I would restrict my talk to the use of prisms in strabismus. So a little bit about the basics. So what is a prism? A prism has an apex and a base, and it deviates the light towards its base with the shifting of image towards the apex. So whenever you are placing a prism, the image shift is always towards the apex. A power of the prism, so one prism diopter equals apparent linear displacement of 1 centimeter object away 100 centimeters or 1 meter away. That is one diopter, prism diopter. Coming to the different prism positions, these are the three positions: Prentice, minimum deviation position, and frontal plane position. So Prentice position, as it is showed in the picture, it is perpendicular to your pupillary axis. Minimum and Prentice position generally preferable in the glass prisms. Then we have the minimum deviation position. So why it's called minimum deviation? Because the angle of incidence is equal to the angle of reflection. So here it is. Then the frontal plane position, which is placed parallel to the frontal plane. So a word about Prentice versus frontal position. Any deviation, if we are measured over a Prentice and then measured in a frontal position, it always tends to overestimate in a Prentice position, as you can see in this graph. Then coming to the stacking of prisms, if the amount of measured deviation is above than the available prisms, ideally we should not stack them but split them. Splitting of the prisms reduces, because it will reduce the stacking errors. Although it will little bit underestimate the power. So as I have shown in this picture, if you stack a prism, if you split a prism of 35 and say 20 prisms, the combined value is not 50 but a little more. However, up to 30 prisms over each eye, it's less. And this base, I just want to stress that this only works in the comitant deviations. And we can always stack the vertical and horizontal prisms. Coming to the high refractive errors, so basically plus lenses are what? Plus lenses are with their base together and minus lenses are with their apex together. So any patient with a plus lenses will always have a measured deviation less than the true deviation, and minus lenses will show a greater than the true deviation. For example, a myopic patient will have overestimation of the esotropia with the minus lenses. So ideally, either we can measure them with contact lens, or we have some normograms in which we can follow this. As you can see, suppose a patient with -7 diopters is measured over 25 or 30 prisms, the actual deviation will be 26 prisms. Similarly, for hypermetropia, because it tends to underestimate, so we can follow the similar normogram. Coming to the oblique prism, so when we are measuring any combined deviations, we have to follow this Pythagoras formula, and the angle is measured. So this is the Pythagoras theorem, and the power is calculated as P, and angle theta is V by P. So generally how we do is we follow this rotation normograph, and the power of excess of the prism, we have to see subjective and objective. So we have to ask the patient, we will rotate the prism and we will ask the patient to tell us when he is able to accept the power and when he is able to see the single. So it is more of a subjective assessment and more than an objective assessment. Coming to the clinical applications of prism, so it can be diagnostic and therapeutic. So diagnostic uses, we all know, we use it in the form of corneal reflex test, Krimsky, alternate prism cover test in Maddox rod, double Maddox, 4 prism base out, amplitude. I'm not going into the details of these tests. Coming to the therapeutic uses of prisms are in the form of relieving diplopia, restoring binocular vision, and assisting in the fusion exercises. So these are the indications. It can be form of relieving prisms, it can be given in concomitant deviations, and in the form of fusion exercises. So in small angle deviations, in elderly, we can give the relieving prisms. Then cranial nerve palsy is very important in primary gaze to restore the binocular vision, and in aiding in the orthoptic training, like in convergence insufficiency. So coming to the types of prisms, it can be a ground-in prisms or Fresnel prisms. So ground-in prisms are prisms incorporated in the glasses. They are limited to up to 6 prism diopters per lens, but they are permanent and they have better optical quality. But they are thicker lenses and little expensive as compared to the Fresnel prisms. Fresnel prisms are flexible, temporary prisms which can be attached to the spectacles, and they are lightweight. But again, they have their cons of they reduce the acuity and contrast. And higher power can be prescribed in a Fresnel prism. So a word about Fresnel prism. Fresnel prism, as I told, it's a thin, negligible weight, and it is cosmetically acceptable even in higher prisms. Made of polyvinyl chloride, consists of a narrow parallel prisms of identical refractive angle arranged in a plastic sheet. So the power of the prism depends on its angle, not on its thickness. So this is a Fresnel prism trial set. So what are the pros and cons? As I told before, it is a lighter, it is cosmetically superior and convenient, and we can push higher prism diopters in a Fresnel prism, unlike a grounded prism. But again, it has its cons, like it reduces the visual acuity and contrast, and it tends to discolor with time. So difficult to clean. So ideally in a prism trial, it should be done in a non-dominant eye, and should be done for the primary deviation. This I am telling about the non-incomitant squints, where we have to give it for the primary deviation, the eye with the deviation, and it should be done both for distance and near, and there should be a subjective and objective verification. And as I told before, for oblique prisms, subjective endpoint by rotation of the prism. So a few examples. This gentleman presented with decompensated exotropia after cataract surgery, had double vision and doing well with the Fresnel prism in the left eye. This child actually underwent bilateral LR recession and came with consecutive ET. So for some time she was prescribed prisms, grounded prisms, before planning surgery for the consecutive ET. This gentleman, he had a road traffic accident, and as you can see, he has right oculomotor nerve pulse. You can see he has adduction, elevation, and depression limited with the ptosis, and he's doing well with the Fresnel prism. Again, thyroid-related ophthalmopathy. These children do very well with the Fresnel prism because they also have intolerable diplopia. Bilateral sixth nerve palsy. This girl doing well with the Fresnel prism. Again, in nystagmus, prisms have a very important role. Why? Because in two ways, they correct the abnormal posture, head posture, and they improve the visual acuity. So in case of improvement of visual acuity, we can give basin prisms so that, they will improve the convergence and improve the visual acuity of the patient. And in case of correction of AHP, as I have shown in the picture, you have to give the prism with the base opposite to the null zone. So suppose a patient has a null point in a way that nystagmus is minimum in right gaze. So we have to give base in the right eye and base out in the left eye till you plan surgery for the patient. Again, in the treatment of hemianopias, the base can be directed towards the blind area so that the blinding area can be pushed and it can provide into the seeing area, and it can provide a larger field of view. And this can be given like that, one side, or it can be given as Pelly prisms. Then aid to the bedridden patient. As we know that bedridden patient, they want to read, they are always in the supine position, so they can be given spectacles through which they can read comfortably. So a base down prism can be given for them. So it's very important that you should explain the patient about the temporary blur, the adaptation time, and the potential cosmetic issues. But of course, prisms are very useful because they allow symptomatic relief without any immediate surgery. They are very useful for small angle deviations in acute paralytic squints, any residual deviations after strabismus surgery with a very quick relief of diplopia and asthenopia. Of course, they are very patient friendly and non-invasive. These are my references. Thank you.
Just a doubt. I thought Fresnel prisms were more expensive than ground prisms, isn't it? Fresnel prisms are more expensive. They come about 3,000 to 4,000 rupees, and ground prisms are not as expensive as Fresnel prisms, unless maybe your refractive correction is very high and you may not get it. Fresnel prism, cut it and keep it. Don't throw away the, because we use it for hemianopic patients in which you can put the upper segments.
What is your experience on giving oblique prisms? I have seen it in many presentations, but
I have given it to quite a few patients. It
Superior
happens,
oblique
like for
paralysis,
example, no, like you have a patient with exotropia and thyroid. Thyroid is one common example where you have hypo and ezo. So the dictum is like, for example, you find out which is the largest angle. Suppose ezo is largest and hypo is less. Let's say 20 prisms of ezo and 10 prisms of hypo.
Okay.
Then you start with a something like, middle, like combine larger power than this thing, say 25 or 30 prisms, and you keep it with apex in first, and then slowly start rotating apex down.
Okay.
At one point, patient will say that he can make it single.
You are talking about the Fresnel prisms. Right?
No, yeah, Fresnel prism, correct. Are you talking about ground prisms? No, I have no experience in oblique ground prisms. But there is a nomogram. There's a book in some, especially I think Susan Cotter et al. Their book has a nomogram which tells you the exact angle in which you can, paste the prism. But most of my experience with oblique prisms is with Fresnel.
Yeah, for the ground prism, I think you need to, like the opticals should know how to make it.
That's
that
another-
more than us. So that knowledge is not there among many opticals. But sometimes by just decentering higher, the patient has higher refractive error, you can just decenter the glass to get some. But for the oblique prism, I think Fresnel would be a better option.
Okay. Okay.
So our next talk is by Dr. Sandra ma'am. She is a consultant in pediatric ophthalmology and strabismus in Arvind Eye Hospital, Coimbatore, with a vast experience, 21 years experience. So everybody know her. Over to you, ma'am.
Thank you. So I'll be talking about one more non-surgical can we say, but definitely we have to do in theatre only, but it is non-surgical in the sense if we don't open the conjunctiva. It was developed for purpose of strabismus only, but it meant more now for cosmetic purposes. It was developed by Dr. Alan Scott in 1978 and he was purely a strabismologist. But in the meantime, after it was discovered, I think we have lost, and more the orbit people and cosmetology have started adopting the use of Botox. And so it was called as Botox in 1989 when Allergan acquired Oculinum from Scott. So what is it? It's a neurotoxin. I think most of the chemistry behind it will be well known. It causes chemical denervation of the motor end plate and paralyzes the muscle to relieve the spasm or the contraction. So it is by creating a denervation. So it will block the cholinergic like the nerve endings. It will enter the nerve terminal and it will be internalized and leads to something called as functional denervation. So it doesn't act forever. Its action is going to be there for a limited period of time. We say up to 3 months will be the duration of action. So we have Botox, Dysport and Myoblock available, and it has to be like if it is type A, it is available as a dry powder which you have to lyophilize with the saline and then reconstitute. So the one which I am familiar with in my hospital is the Botogenie, which has a 50 units vial. So for the purpose of strabismus, I am now diluting it with 1 cc because it is easier to inject just a 0.1 cc into the muscle and it gives 5 units per 0.1. So earlier when I started, I used to try with the 2 cc dilution because the orbit were more used to this dilution. But what I found was that most of the drug was extravasating out. There is very less space within the sheath, muscle sheath. So it is much easier to inject like 0.1 and that avoids the spread of the toxin. So the dosage will be around 2.5 to 5 units per muscle maximum is what is generally used. But you can reconstitute and you can store in the not in a freezer. It is in the below until it is reconstituted. But after reconstitution, you can use it within a period of 4 hours or sometimes even 1 or 2 days later we do use it. So there are like a lot of indications for Botox in ophthalmology. I have experience only with 2 of these conditions, that is for acute 6-nerve palsy and acute comitant esotropia, and in a few cases of thyroid ophthalmopathy also I have used. I have not used so far in any case of congenital infantile esotropia, but there are a lot of reports of people also using it for infantile or any esotropia as an additive. Like you are doing 3 muscles, you can add Botox as one of the thing, but I usually don't prefer that. I have not used it for such indications. So coming to lateral rectus palsy. So lateral rectus we know, okay, mostly it is most common etiology is diabetes. So which are the cases where we are going to inject Botox? See, when we see a diabetic 6-nerve palsy, our first thought is it is going to resolve by itself. Yes, it does. In most of the cases, it is going to resolve by itself. So when you are seeing the case, if it is very mild, like the esotropia in primary position, and if the abduction deficit is only -1 or -2, when you are seeing the patient for the first time, most likely it will resolve by 2 weeks or 3 weeks or maximum 1 month. In those situations, you did not go for botulinum injection. I would reserve the injection for a large angle, is a diabetic or a mononeuropathy, where you have a larger angle at presentation with like -3 to -4 limitation of abduction, not resolving for 2 visits, then the chances of getting contracture of the antagonist is quite high. And even other thing is the rehabilitation of the patient. Like if they are active, if they are earning member, they lose the livelihood sometimes, because no person is going to give leave for 3 months for them to recover the 6-nerve palsy and come back and join their work. So that aspect also we have to think about. And in such conditions, when we give the botulinum toxin, then definitely the hasten, we hasten the recovery. So those are my thought processes when I advise Botox in diabetic mononeuropathy. This is the thing, because in neuro clinic there is always a tug. They will say it will resolve spontaneously. We will say that there are definitely certain indications in 6-nerve palsy where we can use Botox, and rehabilitating early is very important, because I know a couple of patients who have lost the job because of this condition. And another thing is, like if you keep on waiting, the success, like even if you are going to do an R&R, it may differ. If you keep on waiting for 6 months till it doesn't recover, then you are forced to do a muscle transplant. Like you have to do some transplantation process. Then instead of that, you can easily do an R&R if you get some degree of recovery. So the success of your surgery also differs. This holds more in cases of 3rd-nerve palsy. Now, in couple of cases of 3rd-nerve palsy also I have injected botulinum toxin, where it prevents the contracture of the lateral rectus. So later on when we do surgery, it is very easy. And sometimes the recovery is also there. So our surgical decision becomes R&R instead of going for some other procedures. So double vision is extremely distressing. You can probably try sticking on one prism to one of your eye and seeing. We get headache, we get nausea, we get migraine. We cannot stand that double vision even for couple of minutes. It is extremely distressing condition, and you are totally inability to and you are totally dependent on somebody, except in the very mild cases of 6-nerve where you can adopt a face turn and you can walk. That way is fine, but otherwise it's really distressing. It causes stress, it causes depression. So yeah, this is what I was talking about. So initially when I started out, used to give a small nick. This was many years ago, almost 10 years ago, when I was working with 6-nerve. All my experience with Botox initially was with 6-nerve palsy. So I used to make a small nick in the inferior fornix, just as how we would approach a surgery, and then under direct visualization used to inject. So we are using now, you can see the 30 gauge needle. Initially started out with the 25, then moved to 27, then to 30. Again, because the hole that you are making in the muscle sheath, it is good if you can use a thinner needle. And also don't take out the needle immediately. Once you inject, you just wait, and then you take and then to take it out slowly. Don't immediately compress it the cotton, because then again everything is going to come out, especially if you are going to give a open sky technique. So this is like a patient, you can see 20 prisms, and 1 month after Botox he is completely, his abduction has come from -3 to fully recovered. So then coming to Botox in acute comitant esotropia. So initially I was injecting a lot in 6-nerve palsy and had like 3 or 4 years of experience there before starting out on ACE. So ACE, we had lot of patients coming in. What is the time? We have time. Okay. So we had lot of patients coming in during the corona pandemic, much more than what we were seeing initially. And at that point of time, started trying on a couple of cases of ACE and found a really good result, in the sense that it was totally avoiding the need for surgery later on. So ACE in COVID era is mainly linked to smartphone activity, because in small children, especially in small children, even in 4 years or 5 years age group, we have seen acute comitant linked to excessive gadget usage. And more than that is like we wouldn't think, but there are very many kids who are using it even for more than 3 to 4 hours continuously, and that leads to like a spasm kind of thing, but there is no myopia. It is not like a pseudo myopia picture, but it is a different kind of spasm where you have only the medial rectus starts overacting, and then we notice the acute comitant esotropias. And see, this is another study which had come up where you see the number of cases between it's like definitely more during the pandemic than before or after, and that is very specific for the ACE cases in one clinic. I think most of the clinics in India we noted the same problem, but the important thing is to come to the diagnosis, confirm the diagnosis of ACE. Always rule out accommodative esotropia, because the age of onset is almost similar. You have to rule out the accommodative component. you have to rule out a nerve palsy, you confirm that it is committant, and then also it is better to do MRI, because very rarely we do come across some tumors of the cerebellum, brainstem and all associated with acute committant esotropias. And spontaneous recovery is very unusual. Like we have seen lot of cases where the first visit when they come, we advise them to limit the excessive near activity. We do a cyclorefraction. In 2 or 3 cases, just by that cyclorefraction, that spasm has got resolved. Very, very rare, but it has resolved. And again, by just limiting all the device usage, it has resolved in very few number of patients. So don't advise it in the first go. Just advise them the possibility of Botox, ask them to do the cycloplegic refraction, ask them to stop the excessive near activity and review maybe after 10 days or so. If again you are documenting the same excessive near activity, then if you are documenting the same angle, then you may proceed with the botulinum toxin injection. The dose is almost the same. Only thing is here, because the lateral rectus is acting, you go for a smaller dose than what you will do in a 6-nerve palsy. So we had a series of, I forgot the number of cases. Probably we had around 50 or 60 cases where we have tried, and around 60 to 70% of the cases it was a full cure. Like we did not need to go ahead with the surgery at all. So now we are doing transconjunctival approach. So less than 20 PD, it is like 3 units, 20 to 55 and more than 56. Usually I inject only in one eye. If it is more than this angle, then we will, if it's a very large angle, then we go with the bilateral injection. And if it is working, you will know within the first visit. That is first week after injection, it will be resolved, fully resolved. If you are having a residual angle, then definitely it means that it is going to recur after maybe another 2 weeks later, it will come back to the original angle. So that is all that you need to wait for. It is very less invasive, fast recovery, very good option in variable angle, because what happens is in sometimes we do not get a stable angle. So instead of going for surgery, this will form, and this is not dose dependent. You just need to break that cycle and spasm and then it will work. There is no exact dose dependence here. But a surgery, you will need to exactly get a angle and measurement. Yeah. So again, some more role of Botox may be in infantile esotropia, but we do not see the patient so early. If we are seeing it very early, soon after the onset, then this may form an option. I think couple of people in US have tried so, and they also claim that it can sometimes cure the infantile esotropia. Sometimes if you use it in addition as a third muscle, the problem is if there is no binocularity, it is again going to recur. So I think the one thing that will help to maintain the stability of whenever you inject Botox is the fact that the patient has a capacity of binocularity and stereoacuity. If that is not there, if the child has already gone to suppression, Botox will never work. It will only be a temporary injection. Thank you.
Thank you, ma'am. Just one question, ma'am. In patients with Botox, any experience, any patients with ptosis after Botox?
Yeah, many patients can get mild moderate ptosis. Patients can get exotropia. All these things we can explain to the parent, but all these are very temporary. And we will not usually get a severe ptosis, but once we have changed to a transconjunctival approach, the chances of ptosis are very less.
Transconjunctival approach is
very less, because the amount we are injecting is very less. And once you are going transconjunctival, there is conjunctiva, there is tenon, and then the muscle sheath, then you are injecting there. So the chance of it extravasating and spreading is very less.
Thank you, ma'am.
Thank you.
Our next talk is by Dr. Neena, ma'am. I would like to thank Neena, ma'am, because she has obliged to speak on 2 talks. One of our speakers, Dr. Rajesh Prabhu, was unable to come. So thank you, ma'am. And Dr. Neena is department head in pediatric ophthalmology, strabismus and neuro-ophthalmology in Giridhar Eye Institute with so much experience, 21 years experience. Over to you, ma'am.
Thank you, Ranjini. I'm not sure whether we have time for the second talk, but I'll try to see. So the topic given to me is mastering management of complex strabismus. I don't think we can master in 8 minutes, but I will try to give you a few pearls as to what we can do. So the basic thing is to take a detailed history, look at old pictures and surgery reports, do a meticulous ocular motility evaluation and measurements in, if possible, in 9 cardinal positions of gaze, do diagnostic tests like force duction test and force generation tests, blood test to rule out atypical conditions like thyroid ophthalmopathy, ocular myasthenia needs to be done in atypical cases. Imaging is important when you are dealing with a complex strabismus. Always be prepared for intraoperative surprises. Counsel the patient for staged surgery and keep prisms and Botox in your armamentarium to tackle the residual squint. So most of the time when you have a complex strabismus, I would probably talk about a paralytic strabismus or a restrictive strabismus, not your usual comitant strabismus. So it's an incomitant strabismus, and most of them would be having an abnormal head position. So what is driving the abnormal head position? If you can understand, then probably you can tackle that, and that will help you in correcting the cause. So identify the cause and treat the cause, and most of the time it would involve weakening the tight muscle, strengthening the weak muscle, improving ocular motility, trying to reduce diplopia in the primary gaze, and give a shot at enabling binocular vision to the patient. So I will start my cases with this 21-year-old college student who came to me with was concerned about his left face turn, and he had abnormal head posture and eye movement since birth. You can see he has a left face turn, and if you can see this animation, you can notice that he has abduction limitation, -3 abduction in the left eye with palpebral fissure changes. This is suggestive of an esotropic Duane's retraction syndrome with left face turn. So we did a force duction test, which was positive for medial rectus, and we went ahead, and he was basically concerned about the face turn. So there was no upshoot, downshoot, no globe retraction. It was just an abduction -3 with palpebral fissure changes. So we went ahead and did a medial rectus recession and a superior rectus transposition to the lateral rectus, and you can see that his abduction has improved from -4 to -2, and his face turn was much better. So this is a superior rectus transposition happening, and the standard surgery in which you transpose the superior rectus to the lateral rectus, and you can augment it with non-absorbable sutures for better effectiveness. I think I'll just fast forward the video. Yeah, so here the superior rectus is attached next to the lateral rectus, and we are kind of augmenting with non-absorbable sutures. So this was another 7-year-old boy who was ridiculed by his classmates, and he had stopped going to school because they were making fun of his abnormal head posture. Again, he's having a left esotropic Duane's retraction syndrome. So again, we did the same thing. Force duction test showed a tight medial rectus in the left eye, and so the angles were larger here. So what did we do? We did left medial rectus recession, and again superior rectus transposition to the lateral rectus. You can see the HP is well corrected after surgery, and even his abduction has improved in the left eye. So coming to a more complex Duane's retraction syndrome. So this boy presented to us again with left face turn, but the squint was visible in the normal eye. The left eye was having Duane's retraction syndrome with abduction of -3, but it was the right eye which was squinting with hypertropia and esotropia. It was more like a DVD, not a true hyper, but the right eye was unmaintained. So we were like worried whether is this an upshoot of Duane's in the other eye, or is it an updrift of the DVD? That was a confusion, but he eventually found that it was an updrift of DVD in the right eye, and he was fixing with the Duane's eye. So what to do in this patient? So again, force duction test was done. It was positive for medial rectus in the left eye, but since he was manifesting squint in the right eye, we had to do surgery in the right eye also. So what we did was we did asymmetrical medial rectus recession here, very small angle in the left eye, and a larger medial rectus recession in the right eye, and That actually improved his head position. And also we did an inferior oblique recession in the right eye to take care of the large DVD. You can see miraculously his face turn has disappeared and his DVD is well corrected and esotropia is also well corrected. So the surgery standard medial rectus recession, but I did asymmetrical, more in the in the unaffected Duane side than in the Duane side. So another girl with exotropic Duane's retraction syndrome of the right eye with left face turn. Now exotropic Duane's is quite rare, and here again what I did was I did a bilateral lateral rectus recession, asymmetrical, more in the better eye than in the Duane's eye, along with a Y split to take care of her upshoots and the abduction, upshoot and her exotropia. So moving on to restrictive strabismus due to thyroid ophthalmopathy, you can see this lady has a large right ESO and hypotropia. She was found to have bulky extraocular muscles, especially the tight medial rectus and inferior rectus. FDT was positive. So what we did was we did a recession of the medial rectus in the right eye along with an inferior rectus recession, and you can see she's much better cosmetically and functionally after surgery. So this was a 28-year-old painter who came to us with an head injury, post-head injury with severe diplopia and down gaze. This is how he looks, a right head tilt. So we can imagine what he's having. He's having a left superior oblique palsy with intractable diplopia, large angles. So what did we do? We did surgery in both the eyes. We did weakening of the antagonist in the left eye, that is the left inferior oblique recession, and coupled it with an inferior rectus recession in the good eye. And you can see he's much better after surgery. The head post is abolished. He became totally diplopia free and he was able to go back to work. So squint surgery can really help to get over diplopia if you're able to get a good measurement and find out where is the maximum deviation and do surgery accordingly. So this was a case of bilateral 6-nerve palsy, and this patient was very depressed because he was having severe diplopia. We did vertical rectus transposition to lateral rectus. This is one of my old cases. Now I do Nishida for most of them, but in this case we did vertical rectus transposition to the lateral rectus, and you can see he's much better after surgery. Of course, he had some residual esotropia for which we gave him prism glasses. Why did we do transposition in these patients? Because force duction test was negative. It was a case of paralytic strabismus. Now coming to this 6-year-old girl who came to us again with a very large angle esotropia. She had a pontine glioma post-excision and radiotherapy. She landed up with this horrible diplopia and squint. She refused to go to school, and we had to do something for her. So this is how she was. In this case, I wanted to buy some time and I wanted to see how she's going to behave after surgery. So I gave Botox to the medial rectus. So this is one condition you can actually give Botox. You can see she became pretty good. She was so happy after Botox, but the effect lasted only for 3 months. And then we had to go ahead and do bimedial recession and a superior rectus transposition to lateral rectus in both the eyes. She's much better in the primary position. Although she still has limitation of abduction, her angles have come down a lot. So this, you can imagine what it would be. This child with chin-up posture, right upper lid ptosis, right hypertropia is a classic case of monocular elevation defect. We usually see such patients and they have this head posture from birth. And after treating his amblyopia, we took him up for surgery. Of course, FDT was negative. So we decided to do a modified Nishida. In modified Nishida, there is no disinsertion of the muscle. We just take 1/4 of the muscle and we transpose it superiorly. Both the horizontal recta transposed to the superolateral and superomedial compartments towards the superior rectus to give an upward pull and taking to improve the elevation. And you can see after surgery, his elevation has improved to -2 from -4, and in the primary position he became orthotropic. So that was and we of course augmented these, these cases are done with non-absorbable sutures, and this is a big, game changer in strabismus surgery because you don't have to disinsert the muscle at all. So this gentleman had a left horizontal gaze palsy with a left sixth nerve palsy. Now you can see he has a large angle esotropia. Along with that, he also has a left face turn because he has left horizontal gaze palsy with sixth nerve palsy. So in this case, I didn't know really what to do. But since he also had a sixth nerve palsy, I went ahead and did an FDT, which was negative, and we did a medial rectus recession of the left eye with superior rectus transposition to lateral rectus. He's much better after surgery, though he's not able to move his eyes to the right, but his primary position squint has improved and improving his head posture. Another lady post CP angle tumor excision, combined sixth and seventh nerve palsy, very bad diplopia and lag of thalamus. We undertook her for medial rectus recession. After FDT, confirming it to be negative, we did medial rectus recession in the left eye with superior rectus transposition to the lateral rectus and a tarsography, and she became much better. A word about nystagmus with face turn. These are complex surgeries. Patients will come to you with nystagmus with abnormal face turn. Like this boy, he had this 30-degree face turn. So this is him after Kestenbaum-Anderson's procedure. You can see he didn't have a squint, but he only had abnormal head posture due to nystagmus. So there are various modifications, Wright's modification, augmented Kestenbaum you can do. You have to individualize depending on the patient's face turn and presence of any strabismus or not. Another lady with nystagmus and a right exotropia, I only did an Anderson's procedure here because she had a left face turn. That means she's having, her eyes are fixed in right gaze. So I just weakened the right eye was exotropic also. So I just weakened the right lateral rectus and tightened the right medial rectus. That took care of both the strabismus and her nystagmus. She became much better after surgery. So I'd like to end that. I think no presentation is complete when it is a complex strabismus. These are all just some pearls that you can understand, but every patient has to be individualized and the management cannot be tailor-made for all patients. Thank you.
Thank
Do
you,
we
ma'am.
have time? I think we just
think
have,
it's time.
we don't
Yeah,
have time.
time.
So I think Dr. Rajesh was unable to come due to an emergency. So if there are any questions, we can take questions.
I just have one question, ma'am, regarding transposition procedures. In what all cases you do Foster augmentation, or you do it routinely for all cases? Any specific
All
indication?
paralytic strabismus you need to do, but when you do for Duane's, I don't generally do a Foster's augmentation because most of the time, because sometimes these Foster's augmentation can produce torsion. And Duane's is not a true paralytic strabismus. It is, you have to see the tone of the muscle. The lateral rectus is not dead there. It has abnormal tone, that's it. So you have to look at the FDT, FGT, everything. And most of the time I get away with just a transposition. I don't do a Foster's augmentation. But for other paralytic strabismus, if the angles are large, at least if it's more than 25, 30, usually I put in a Foster's augmentation suture.
Thank you, ma'am. Do you have?
Madam, so in MAD, you prefer doing modified Nishida rather than inverse naps?
No.
Regarding the
I'm going
updating,
to
no?
come to that. It's my experience in small angle MADs, that is less than say 20, 25, Nishida works very good in my hands. But for larger MADs more than 35, I prefer naps.
Okay.
Because in my hands, the Nishidas gives around 25 maximum. That's what I have seen. Though there are reports of people doing Nishida for very large angle strabismus, but Nishidas gives me maximum 20, 25. So it does not give me more than that. But when you have very large angles, I do prefer to do a naps.
Till what age do you wait for doing surgery in an MAD?
Yeah, so I don't jump into surgery. If there is amblyopia, please treat it. Most of them will be amblyopic. The vision should at least they should come more or less equal to the other eye, unless it is such a bad strabismus, child is not able to even bring the eye to midline to fix. Then you can do surgery. But most of the time, once the eye is straight, parents will stop patching.
Yeah.
And so that is another thing that we have to worry about. The amblyopia component should be taken care of, and you should be able to get a good measurement. If you are able to get a good measurement at 2 consecutive visits, almost stable, you can definitely go ahead with surgery.
Recently, I had a child, 1 year of age. I saw her at 1 year of age. Very prominent head posture. That was the main concern
But that's
for
good.
the
In that
parents.
case, the child will be fusing. If the head poster is there, you can tell the parents that that head poster is adopted to, use both the eyes together. So you can, try patching for some time and treat any refractive errors, and till you get a very good measurement. I don't do Nishidas on just guesswork. I have to get good measurements. What is your take, Dr. Sandra?
Angle. Sometimes when you put the patch also, they have to adopt a very
Yeah,
severe head
yeah.
posture. In that situation, I may decide to operate a little earlier.
Yeah.
But as you said, the forced action should be negative. That is one thing. And larger angle, definitely Foster's will give a better. Naps with Foster is the choice rather than Nishida. Nishida I usually reserve for like the older patients who like older where because it takes very less time to do the procedure. So otherwise I usually go with Foster's naps.
So that's an end for an IC. I would like to thank.
Take a picture together.
Yeah, I
A
would
quick
like to
picture.
thank all the speakers, Namita, Sandra ma'am, and Neena ma'am for coming and speaking on this IC. Thank you so much.